All right, let's jump into this deep dive. Today we're focusing on something you know like the back of your hand as medical lab scientists. We're talking about lipids, that cornerstone of general
Yeah,
chemistry.
lipids.
Yeah.
And it's not just the textbook stuff. We're going to bridge that gap between the textbook and what you actually do in the lab.
Because you're the ones running those tests, generating those lipid panels. You're analyzing those results that are so important for patient care.
Exactly. It all comes down to understanding what those numbers mean, connecting the dots between fundamental chemistry, the tests, and the bigger picture of health and disease.
So think of this as your one-stop shop, a sort of comprehensive deep dive into the world of lipids. We'll look at their roles in the body, how we measure them, and what those measurements tell us.
We'll break it down into those key areas that are super relevant to your work as MLS professionals. The biochemical nuts and bolts, how we test for them, the ins and outs of interpreting those results, and of course, how it all ties back to disease.
Sounds good to me. Okay, let's kick things off with lipids as those biochemical powerhouses. They're a lot more than just fats, right?
Oh, absolutely. They're super versatile molecule. First off, think about energy storage. Triglycerides, they're like our body's go-to energy reserve, a way to store tons of energy really efficiently.
Right, makes sense.
And then there's their structural roles. Phospholipids and cholesterol are the backbone of all our cell membranes. They're essential for keeping those cells intact and functioning properly.
And cholesterol doesn't just stop there, right?
Not even close. Cholesterol is also a precursor to those all-important steroid hormones. Those hormones are involved in a whole slew of bodily processes, everything from growth and development to regulating metabolism and the immune system.
So these molecules are constantly busy working hard behind the scenes, and keeping them in check is a whole network of metabolic pathways. Where should we even start to untangle that web?
Well, a good place to start is lipolysis. It's basically the breakdown of triglycerides. This all goes down in the cytoplasm of fat cells, those adipocytes, and it's triggered when your body needs to tap into those energy reserves. The star of the show here is an enzyme called hormone-sensitive lipase. This enzyme, though, is under tight control.
Controlled by what?
Hormones, of course. Insulin puts the brakes on lipolysis. It says, hey, we've got enough energy floating around, no need to break down those triglycerides. But when energy is in demand,
Then what happens?
hormones like glucagon, epinephrine, and even cortisol step up and say, all right, time to release some fuel. They stimulate that hormone-sensitive lipase. It's all about balance, making sure your body has the energy it needs when it needs it.
So it's a finely tuned hormonal dance, basically. And what happens to those fatty acids once they're released from those triglycerides?
Well, they head straight for the mitochondria, those powerhouses of the cell. They go through a process called fatty acid oxidation or data oxidation. It's like a disassembly line where those fatty acids are broken down into smaller pieces, those two carbon molecules called acetyl-CoA. Acetyl-CoA is a key player in energy production. It enters the Krebs cycle, and that's where the magic happens.
Magic meaning.
ATP production. ATP is the cellular currency of energy. And fatty acid oxidation is a super efficient process. Just take palmitic acid, for example. One tiny molecule of palmitic acid can generate a whopping 129 ATPs.
Wow, 129 ATPs. That really drives home how energy-dense fats are. Now let's flip the script. What happens when we have more than enough energy? What happens to the excess?
That's when lipogenesis kicks in.
Yeah,
This is the pathway that builds fatty acids from acetyl-CoA.
all right.
It primarily occurs in the liver and adipose tissue in the cytoplasm. And here's the thing, acetyl-CoA is made in the mitochondria, so it has to take a little shuttle bus, the citrate shuttle, to get to the cytoplasm for lipogenesis.
Interesting.
A key step here is turning acetyl-CoA into malonyl-CoA. This conversion is controlled by an enzyme called acetyl-CoA carboxylase, which is, like many things in the body, influenced by hormones.
So insulin probably promotes it, and glucagon probably inhibits it, right?
Exactly. Insulin is like, hey, we've got plenty of energy, let's store some as fat. Glucagon, on the other hand, signals that energy is low and says, hold off on making new fatty acids. And of course, other molecules like citrate and palmitoyl-CoA also play a role in regulating this enzyme. And once malonyl-CoA is made, fatty acid synthase comes into play. It basically adds those two carbon units from malonyl-CoA together like building blocks to make a fatty acid chain. The primary product of this whole process is palmitic acid.
So it's like a constant cycle, breaking down when we need fuel and building up for storage when we have extra. And those newly made fatty acids end up stored as triglycerides.
You got it. Triglyceride synthesis is where those fatty acids get hooked up with glycerol-3 phosphate, This happens in the cytoplasm of liver and fat cells.
Makes sense.
Glycerol 3-phosphate can come from different sources.
Mm.
In the liver, it can come directly from glycerol. But in fat cells, it's mostly made from DHAP, dihydroxyacetone phosphate. It's a molecule involved in glucose metabolism. The availability of both fatty acids and glycerol 3-phosphate, along with good old insulin, controls this whole triglyceride synthesis process.
Okay, so we've got the triglycerides covered. How about cholesterol? How's that made?
Cholesterol synthesis. That's a bit more of a complex pathway. It's a multi-step process that happens mainly in the liver, and it takes place in both the cytoplasm and the endoplasmic reticulum.
All right.
It all starts with acetyl-CoA and eventually gets turned into HMG-CoA. Now, the enzyme that controls this step, HMG-CoA reductase, is the rate-limiting step. It's like the bottleneck of the whole pathway.
Gotcha.
And you know what targets HMG-CoA reductase? Statin drugs. Those medications we use to lower cholesterol levels. And of course, the activity of this enzyme is influenced by cholesterol levels themselves, statins, and our friend insulin. And once cholesterol is made, it has a few different fates. It can become part of cell membranes to help give them structure and stability. It can be used as a starting material to make steroid hormones and bile acids, which are important for digesting fats, or it can be packaged into lipoproteins for transport around the body.
And that takes us straight to lipoprotein metabolism. This is super relevant when you're interpreting those lipid panels. Can you give us a quick rundown of how that whole system works?
Absolutely. So lipids are hydrophobic, right? They don't mix well with water, so they need a special transportation system to move around in the bloodstream.
Hence, lipoproteins.
Exactly. They're like tiny cargo ships. They have a core made up of triglycerides and cholesterol esters. And this core is surrounded by a shell.
What's in the shell?
Phospholipids, free cholesterol, and special proteins called apolipoproteins. Now, there are different types of lipoproteins. Chylomicrons, they're the ones that carry dietary fat, the fat you eat, from the intestine to the rest of the body.
Okay.
Then you've got VLDL.
Very low-density lipoprotein.
Yep. VLDL is made by the liver, and its job is to transport triglycerides that are made in the body. As VLDL travels around, it loses some of those triglycerides thanks to an enzyme called lipoprotein lipase, or LPL.
What activates LPL?
One of the apolipoproteins on VLDL, ApoC2. It's like a signal that tells LPL to get to work. This whole process turns those VLDL remnants into IDL.
Intermediate density lipoproteins.
And eventually, IDL turns into LDL, the so-called bad cholesterol.
Right, because LDL carries cholesterol to tissues, and too much of it can be a problem.
Exactly. Cells take up LDL through LDL receptors. It's called receptor-mediated uptake. And then you have HDL, good cholesterol.
Produced by the liver, right?
The liver and the intestine. HDL's job is the opposite of LDL. It does reverse cholesterol transport. It goes around picking up excess cholesterol from tissues and brings it back to the liver. The liver can then get rid of it or use it to make bile acids.
So it's like a cleanup crew, removing excess cholesterol. That's a great overview of that whole lipoprotein highway. Now let's talk about some of the physical and chemical properties of lipids. Let's start with those lipoproteins. What gives them that unique ability to transport fats?
Well, it all boils down to their structure. Like we said, they have that hydrophobic core that carries those insoluble triglycerides and cholesterol esters. And surrounding that core is a shell that has both water-loving and fat-loving parts.
You call that amphipathic, right?
Exactly. This amphipathic shell is made of phospholipids. They have a polar, water-loving head and non-polar, fat-loving tails, as well as free cholesterol and those apolipoproteins. The density of a lipoprotein depends on how much lipid and protein it has. HDL, with more protein, is denser than LDL, VLDL, and chylomicrons, which are loaded with lipids.
So that's how we get those different density classifications. And the apolipoproteins, they're more than just structural components, right?
Oh, absolutely. They're like the address labels and the keys that allow those lipoproteins to dock at the right cells. They act as recognition signals for receptors on cells, directing those lipoproteins to their target tissues. They can also activate or inhibit enzymes that are involved in lipid metabolism.
Can you give us an example?
Sure. ApoC2 on VLDL, the one we talked about earlier, activates lipoprotein lipase, and ApoAE, which is found on HDL, activates LCAT, lecithin cholesterol acyltransferase, which is involved in reverse cholesterol transport.
So those apolipoproteins are pretty important players. What about phospholipids themselves? What makes them so special?
Their claim to fame is their amphipathic nature. That hydrophilic head and those hydrophobic tails are key to their main job, forming the lipid bilayer in cell membranes.
Right, that double layer that surrounds every cell.
Exactly. In a watery environment, phospholipids arrange themselves spontaneously. Their tails point inward, hiding from the water, and their heads point outward, embracing the water. They form a barrier, essentially.
And this barrier isn't static, is it?
Nope. The phospholipids are constantly moving, giving the membrane fluidity. That's super important for the membrane to function properly. Phospholipids can also be broken down by enzymes called phospholipases, and some of the products of that breakdown can act as signaling molecules within the cell.
So it's a dynamic structure. What about triglycerides? We know they're the main energy storage, but what are their key properties?
Triglycerides are mostly nonpolar and really, really hydrophobic. They don't like water at all. That's why they can pack together so tightly in adipose tissue and in the core of lipoproteins.
Okay.
They're made up of 3 fatty acids linked to a glycerol backbone. And those links are ester bonds, which are broken down by enzymes called lipases to release those fatty acids when we need energy. And because triglycerides are basically long chains of hydrocarbons from those fatty acids, they're a super concentrated form of energy storage.
Makes sense. And finally, let's touch on cholesterol's properties. We know it's essential, but what are its key physical and chemical characteristics?
Cholesterol has a unique structure. It's a rigid, flat steroid ring that's very hydrophobic. That rigidity is what makes it so good at providing structural support in cell membranes.
Right, it helps to maintain that membrane integrity.
It also has a single hydroxyl group, which gives it a slightly amphipathic character. This allows it to orient itself within the lipid bilayer. And importantly, that steroid ring structure is a foundation for making all the steroid hormones, like cortisol and the sex hormones, as well as bile acids, which are essential for digesting fats.
And we can't forget about cholesterol esters.
Right. Cholesterol can also be esterified with a fatty acid at that hydroxyl group. This makes it even more hydrophobic, and that's the form it primarily takes when it's being transported in lipoproteins.
So that wraps up our exploration of the biochemical world of lipids. Now let's shift gears and put on our lab coats. It's time to talk about laboratory test procedures. From a medical lab scientist's perspective, what are the key principles behind the core lipid panel?
So the core lipid panel, you've got your total cholesterol, triglycerides, HDL-C, and LDL-C. It's the bread and butter of lipid testing.
For sure.
When we measure total cholesterol, it usually involves a series of enzymatic reactions. First, any cholesterol esters that are hanging around get broken down into free cholesterol. That's the job of cholesterol esterase.
Okay.
Then, cholesterol oxidase comes along and oxidizes the free cholesterol. This produces hydrogen peroxide. And that hydrogen peroxide reacts with a special dye, a chromogen, in the presence of peroxidase, resulting in a colored product.
And we can measure that color, right?
Exactly. The intensity of the color, which we can measure with a spectrophotometer, tells us how much total cholesterol is in the sample.
It's a pretty clever way to quantify it.
And for triglycerides, we use a similar approach.
Really?
Yep. First, lipoprotein lipase breaks down the triglycerides in the sample into glycerol and free fatty acids. Then, a series of enzymatic reactions convert that glycerol into a product that ultimately leads to more hydrogen peroxide.
So it's the same endpoint as the cholesterol assay.
Right. The hydrogen peroxide reacts with a chromogen in the presence of peroxidase, forming a colored compound that we can measure. The color intensity is directly proportional to the triglyceride concentration in the sample.
So the principles are similar. How about measuring HDL-C? It seems a bit trickier since we have to separate it from all those other lipoproteins.
You're absolutely right. We have direct and indirect methods for doing that.
Can you walk us through those?
Sure. Indirect methods usually involve adding a special reagent that precipitates out the non-HDL lipoproteins like LDL, VLDL, and chylomicrons. We spin the sample in a centrifuge, and the HDL stays in the liquid part, the supernatant. Then we can measure its cholesterol content using the same enzymatic methods we talked about for total cholesterol.
And what about those direct methods?
Direct methods are becoming more common because they're easier to automate. They use specific antibodies or detergents that block the non-HDL cholesterol from reacting, so we can directly measure the cholesterol in the HDL particles.
I see. And LDL-C is often calculated, isn't it?
Yes, often using the Friedewald equation. It's a simple equation that takes into account total cholesterol, HDL-C, and triglycerides.
And how does that work?
It's basically LDL-C equals total cholesterol minus HDL-C minus triglycerides divided by 5. That division by 5 estimates the VLDL cholesterol. It assumes most of the triglycerides are carried in VLDL. But there's a catch. This equation only works when triglyceride levels are below 400 mg/dL.
Why is that?
Because if triglycerides are super high, that assumption that most are in VLDL doesn't hold true anymore. So the Freewold equation becomes unreliable. In those cases, we need to use direct methods to measure LDL-C, just like with HDL-C.
So it's important to know when to use which method. Now, apart from that standard lipid panel, what other lipid-related tests might medical lab scientists come across, and what are the principles behind those?
Well, you might see orders for apolipoproteins, specifically ApoAI and ApoB.
Right, those are the ones we talked about earlier that ride along on lipoproteins.
Exactly. And then there's lipoprotein A, or LPA. These are usually measured using immunochemical methods.
Can you give us some examples?
Sure. There's turbidimetric immunoassays, nephelometry, and enzyme-linked immunosorbent assays, or ELISAs. These methods all rely on antibodies that specifically bind to the target protein.
And how does that translate into a measurement?
In turbidimetry and nephelometry, we measure how much light is scattered by the antibody-protein complexes. In ELISA, we measure the activity of an enzyme that's linked to the antibody. In all these methods, the signal is proportional to the concentration of the apolipoprotein, or LPA, in the sample.
So it's all about detecting those specific proteins.
Right. And then there's lipid electrophoresis. This technique separates lipoproteins based on their size and electrical charge. They migrate through a gel, and then we stain them with a special dye that binds to lipids.
And that allows us to see
The different lipoprotein fractions.
Yeah.
It's really helpful in diagnosing certain genetic lipoprotein disorders.
So we've got a whole toolkit for analyzing lipids. Now, accuracy is paramount in lipid testing. What are some of the key precautions that our listeners, those working in the lab, need to be mindful of throughout the entire testing process?
Absolutely. I think we can break it down into 3 phases: the pre-analytical phase, the analytical phase, and the post-analytical phase.
Okay, so starting with the pre-analytical phase, what are the key considerations there?
Well, it starts with patient preparation. For triglycerides, we need that 9-12-hour fast. Triglycerides can be significantly elevated after a meal, so that fasting period is essential for getting an accurate result.
Makes sense. What about other patient-related factors?
Medications are a big one. Lots of drugs can influence lipid levels, so it's crucial to know what medications the patient is taking.
Can you give us some examples?
Sure. Statins, for example, are used to lower cholesterol. Fibrates mainly lower triglycerides. Beta blockers, oral contraceptives, corticosteroids, that they can all affect lipid levels. Then you have to consider underlying medical conditions: diabetes, thyroid disorders, kidney disease, liver disease. All these can impact lipid metabolism. And even acute illness or recent surgery can throw things off temporarily.
So it's really important to take a good patient history.
Absolutely. And even something as simple as the patient's posture right before blood collection can make a difference.
Really? How so?
Well, if a patient has been standing for a while before the blood draw, their plasma volume might be slightly lower, which can lead to falsely elevated lipid levels. That's why we ask patients to sit for a few minutes before the draw.
That's a good point. So we've covered the pre-analytical phase. What about the analytical phase? What are the key things to watch out for in the lab?
Quality control, quality control, quality control. That's the mantra. We need to make sure everything is running smoothly and that our results are accurate.
Absolutely. What are some of the specific things that fall under quality control?
Well, first off, using reagents that haven't expired is crucial. We also need to calibrate our instruments regularly using appropriate standards. And we have to run quality control materials, samples with known values, to make sure our assays are performing correctly. We only report patient results if those controls are within acceptable limits.
And I imagine interfering substances can be a big challenge. Lipemia immediately comes to mind.
Lipemia is definitely a common one. It's that cloudy appearance of the blood when there are high levels of lipids. And that cloudiness can interfere with spectrophotometric measurements because it scatters light.
So it can affect the readings.
Exactly. And then there are other endogenous interference like bilirubin, which can absorb light at specific wavelengths, and hemoglobin from hemolyzed samples, which can also cause spectral interference and sometimes affect enzymatic reactions.
So those are interference that are present in the sample itself.
Right. But we also have to watch out for exogenous substances, things like ascorbic acid, vitamin C, and certain medications or contrast dyes can also interfere with some assays.
So being aware of potential interference is key. And what can labs do to mitigate these interferences?
Well, we need to have protocols in place. For severe lipemia, for example, we might use ultracentrifugation or special chemical clearing agents to remove those lipids before analysis. We also need to pay attention to the patient's medication list and look for signs of hemolysis or icterus, which is that yellowing of the skin or eyes that indicates high bilirubin. It's all about being vigilant and taking steps to ensure the accuracy of our results.
Makes sense. Now let's move on to the post-analytical phase. We've got our results. How do we interpret them? What are the key reference intervals and their clinical significance?
So remember, the reference intervals are guidelines, but we always have to consider the whole clinical picture when interpreting results.
Right. It's not just about the numbers in isolation.
It's exactly. For total cholesterol, generally, we like to see it below 200 milli-GDL. That's considered desirable. 200 to 239 milli-GDL is borderline high, and anything at or above 240 milli-GDL is considered high.
Okay. And triglycerides.
For triglycerides, below 150 milli-GDL is usually normal. 150 to 199 milli-GDL is borderline high. 200 to 499 milli-GDL is high. And then 500 milli-GDL or higher is very high. And that very high level really increases the risk of pancreatitis.
Right, that inflammation of the pancreas.
Exactly. Now, with HDL-C, we actually want to see higher numbers. Below 40 milli-GDL is considered low and a major risk factor for cardiovascular disease. 60 milli-GDL or higher is considered protective.
So it's kind of the opposite of the other lipids.
Right. And for LDL-C, the goals really depend on the individual's overall cardiovascular risk. But generally, below 100 milli-GDL is considered optimal for most people.
And what about non-HDL cholesterol?
Non-HDL cholesterol is calculated by subtracting HDL-C from total cholesterol. It gives us a measure of all the atherogenic lipoproteins, the ones that contribute to plaque buildup. The guidelines generally aim for non-HDL cholesterol below 130 milli-GDL. It's especially useful when triglycerides are elevated.
Oh, okay, good to know.
For ApoAI, which is a major component of HDL, lower levels, usually below 100 milli-GDL in men and below 120 milli-GDL in women, are associated with an increased risk of cardiovascular disease. And conversely, higher levels of ApoB, usually above 130 milli-GDL, are also linked to increased risk. Some studies suggest that ApoB might be a better predictor of the number of atherogenic particles than LDL-C.
Interesting.
And finally, lipoprotein A, or LPA. The reference range is typically below 30 milli-GDL or 7500 GL. Elevated levels are considered an independent risk factor for cardiovascular disease, and it's largely determined by genetics.
So a lot to consider when looking at lipid profiles.
Definitely. And it's not just the numbers themselves. It's about understanding the patient's context.
Can you elaborate on that?
Sure. We've already talked about fasting status being crucial for triglycerides, and we know medications can have a big impact. But we also need to consider things like underlying medical conditions, acute illness, recent surgery, ethnicity, age, gender, and even pregnancy. All these factors can influence what we consider normal or abnormal.
So it's about connecting the dots between the lab data and the patient's clinical picture.
Precisely. It's all about putting those pieces together.
This brings us to our final topic, the correlation between abnormal lipid levels and various diseases.
This is where it all comes together. This is where we see how those lipid numbers can translate into real health implications. We know that elevated LDL-C, non-HDL-C, ApoB, along with low HDL-C and elevated LPA, all contribute to atherosclerosis.
Atherosclerosis, that's the buildup of plaque in the arteries, right?
Right. And atherosclerosis is the root cause of coronary artery disease, or CAD. It's what leads to angina, heart attacks, and other cardiovascular problems.
So those lipid abnormalities are really setting the stage for those serious conditions.
Exactly. And when we see elevated total cholesterol, LDL-C, triglycerides, and low HDL-C together, we call that hyperlipidemia or dyslipidemia. This combination significantly increases the risk of a whole range of cardiovascular events, like strokes and peripheral artery disease.
And we often hear about lipids being connected to metabolic syndrome. Can you explain that link?
Sure. Metabolic syndrome is a cluster of risk factors that increase the risk of heart disease, stroke, and type 2 diabetes.
And several of those risk factors involve lipids, right?
Absolutely. Elevated triglycerides, low HDL-C, along with high blood sugar, abdominal obesity, and high blood pressure are all hallmarks of metabolic syndrome.
So it's a multifaceted condition with a lot of interconnected risk factors.
Exactly. And when it comes to lipids, having those very high triglyceride levels, usually above 500 milli-GDL, can lead to acute pancreatitis.
That's a serious inflammation of the pancreas, right?
Yes. It's thought that those very high triglyceride levels overwhelm the pancreas's ability to process them, leading to inflammation.
Makes sense. We also talked about genetic lipoprotein disorders. Can you give us a few examples of how those inherited conditions show up in lipid profiles and what risks they pose?
Sure. One of the most common is familial hypercholesterolemia, or FH. People with FH have very high LDL-C levels from a young age, often over 190 milli-GDL in adults and over 160 milli-GDL in children.
And that puts them at risk for?
Premature heart disease.
Yeah.
They're at a much higher risk of developing cardiovascular problems at a younger age. And this is usually due to mutations in the gene for the LDL receptor, which is responsible for clearing LDL from the blood. There are also mutations in other genes like ApoB and PCSK9 that can cause FH. Then there's familial hypertriglyceridemia, or FHTG. This condition leads to elevated triglyceride levels, usually over 200 milli-GDL. It's often caused by mutations in genes involved in triglyceride metabolism, like lipoprotein lipase or ApoC2.
And what are the implications of FHTG?
Well, it increases the risk of both pancreatitis and cardiovascular disease. It's important to identify and manage these conditions to reduce those risks. And then there are rarer disorders like Tangier disease.
And what causes Tangier disease?
It's caused by a mutation in the ABCA1 gene, which is involved in HDL production. People with Tangier disease have extremely low HDL-C levels, typically below 5 milli-GDL. It can also cause other problems like enlarged orange tonsils, neuropathy, and an increased risk of premature cardiovascular disease.
So a lot of different ways that genetics can impact lipid levels and health.
Absolutely. Genetics plays a big role in how our bodies handle lipids.
Now, last but not least, let's talk about non-alcoholic fatty liver disease. How do lipids tie into that condition?
So non-alcoholic fatty liver disease, or NAFLD, is a condition where fat builds up in the liver, and it's not caused by excessive alcohol consumption.
And how common is it?
It's becoming increasingly common, unfortunately, and it's often associated with dyslipidemia, those abnormal lipid levels we've been talking about. We often see elevated triglycerides, elevated LDL-C, and low HDL-C in people with NAFLD.
Are there any other metabolic abnormalities associated with an AFLD?
Yes, we often see elevated liver enzymes, especially ALT and AST, as well as elevated fasting glucose. NAFLD is closely linked to insulin resistance, obesity, metabolic syndrome, and an increased risk of cardiovascular disease. And in some cases, NAFLD can progress to a more severe form called non-alcoholic steatohepatitis, or NASH. NASH can lead to liver damage, cirrhosis, and even liver failure. So it's a condition that we need to take very seriously.
Absolutely. It's a reminder that lipid abnormalities can have far-reaching consequences. So as we wrap up this deep dive, what are the key takeaways you want our Medical Lab Scientist listeners to remember?
The main takeaway is this: lipids are fundamental to how our bodies work. They play diverse and essential roles, and measuring them accurately and interpreting those results thoughtfully are absolutely crucial for assessing cardiovascular risk, diagnosing metabolic disorders, and monitoring treatment. You, as medical lab scientists, play a vital role in generating those reliable lipid profiles.
And that's no small feat.
Not at all.
Yeah.
Your work is at the heart of patient care. By understanding the biochemistry, the testing principles, and the clinical context, you can contribute even more meaningfully to the healthcare team.
Absolutely. Having a deeper appreciation for the intricate world of lipids empowers you to not only produce accurate data, but also to understand its implications for patient health. So, as we close out this deep dive, here's a thought to ponder. Given all the advances in research and technology, what new frontiers might we see in lipid testing in the years to come? What new biomarkers or analytical techniques might emerge that can give us even more refined insights into lipid metabolism and disease risk? And how might our growing understanding of the genetics of lipid disorders change how we approach diagnosis and management? It's a fascinating area with so much potential for discovery. Thanks for joining us for this deep dive into the world of lipids.
It was a pleasure.
Until next time.